Good morning or good afternoon, everybody, and thanks a lot for the invitation, Philip and Vincent. I'm going to talk about cryoablation for neuralgias and neuropathic pain. And I have to say a big thank you to my dear friend, Andrea Trescott. She taught me cryoablation in 2010, and ever since I've been using it, I'd say often nice and successfully. And you have to, before we get into the disclosures, you have to know her book. This is almost like a Bible. It's a big book. Can't even imagine how it's possible to come up with such a thorough book on peripheral nerves. Many of the images are from this book that you will see among the slides, and I just recommend buying it, reading it. So here's my disclosure slide. I do speak for Medroom and EpiMed, the companies that distribute cryo equipment, and I also speak for a couple of other radio frequency companies, but I'm not employed by any of them. I'm the co-founder of Pain School International. I'm on the WIP Education Committee, and I speak for a couple of societies here and there. So what is good about cryoablation? First of all, this is a technique that can be used on myelinated nerves, and there is no neuroma formation. You can repeat it as many times as necessary because the nerve grows back to the same way, same position, then the pain comes back, but you can repeat as well. And if you provide an optimal environment, then the pain may not come back with it. When do you want to think of cryo? I would say I would group the indications in three main groups. If the problem itself is nerve origin, and that's what we're going to focus on today, all the neuralgias, nerve entrapment, neuropathy, CRPS type 2 is a very good one and can be a game changer for the patient. But of course, you can also use cryoablation if there's a musculoskeletal problem, let's say hip or knee osteoarthritis, and you want to denervate it. And recently, there's more and more interest in using cryoablation for the perioperative pain management and also acute pain. Now, who is the ideal cryo candidate? First of all, you need to be able to think of a clearly identifiable nerve involvement. The history, the physical exam, and the ultrasound scanning all needs to point to the same direction. If you do a positive diagnostic block with very low volume local anesthetic, that's excellent. The literature suggests 50% is good generally for diagnostic blocks. I prefer 80% because that will really get you the success when you get to the true cryoablation. One important thing that the patient needs to understand, that if you freeze a nerve, there's going to be numbness. I think most of us who are doing cryoablation ran into the situation when we took the pain away, and then the patient was unhappy because we gave them numbness. Now, if you look at this pretty recent article on the management of neuropathic pain, of course, you need to start with all the medication management. You need to sort out the mood, sleep, and psychological factors. You gotta have the multidisciplinary approach. And then eventually you will get to the interventional therapies, but only after conservative failed. And if this fails, radiofrequency, cryo, pulse radiofrequency, then you proceed to neuromodulation. Now we need to remember that if you are looking for good evidence, you're going to find some for radiofrequency for neuralgias, and you're going to find much less for cryoablation. So if you put in PubMed, neuralgia and radiofrequency, you find over 1,000 results. And if you put in neuralgia and cryo, you only find 130. Now what's the history? The history dates back really all the way to Hippocrates. That was the first written record of a use of ice pack for pain relief. In 1777, John Hunter described the tissue destruction after cooling rooster cubs and noted good healing and recovery. In 1919, Trendelenburg noted freezing the nerves and loss of function, but eventually healing without scarring. And then later in 1961, Cooper developed the first cryo probe, and later in 76, Lloyd started calling it cryoanalysis. So what is the mechanism of action? This is what happens. It's a reversible neurolysis. You freeze one part of the nerve, you take out or destroy the myelin, and then it eventually grows back. Now what is destroyed is the axon and the myelin, but the perineurium, epineurium, and endoneurium remains intact. That means all the connective tissue around the actual axon stays. That is what will allow the nerve to grow back in the same fashion. This is the Sunderland nerve injury classification. We can talk about first, second, third, fourth, and fifth degree freeze. And the important thing is that the first and second is reversible. First is when you put an ice pack, right? It cools down, takes the pain away, nerve function returns essentially immediately. When they talk about the second degree, that's an axonotmesis, that's the Wallerian degeneration. It happens to minus 100 Celsius, and this is where cryoablation is. If you go any colder, then it's going to be an irreversible damage. This is how the cryo probe looks. This is the whole gear that plugs into the machine. This is the ice ball. You can see I was dripping lidocaine on the tip of the cryo probe, and you can see that there's an insulated shaft, and the tip is where the freezing happens. And I put this here so you see the size of it. It's relatively big size probe, which has some implications when you do the procedure. These are the machines that the probe plugs into, and there are other companies in the market as well. What is the physics? The physics is based on the Joule-Thomson effect. So there is compressed air, nitrous or carbon dioxide, comes very, very compressed, and as it comes out at the tip, it expands and it cools down the tip. And then the gas leaves in an outer tube. You can see that the freeze is time dependent, or the size of the ice ball is time dependent. 15 seconds, it's much slower than at 19 seconds. Freezing any longer than this really doesn't add much because the ice will work as an insulator. So no coolness will come out of the ice ball. The size will eventually not increase. That's why we tend to do twice 2 minutes or twice 90-second freeze cycles. So what do we know about effectiveness and safety? This is an immunofluorescence staining. And if you take a look at the first image here, that's an untreated axon, and the axon is marked by green, and the red is the myelin sheath around it. And once you treat it, in the second week, you can see that the axon disappears, and towards 4 and 8 weeks, it slowly grows back. But by the time everything grows back to full function, that's about 6 months. And this is the hematoxylinosin staining of a rat nerve cross-section. This is the untreated, and that's the treated. You can see the disruption of the axons, while the perineurium and the epineurium is intact. And this is looking at the surrounding tissues, what happens to muscle cells, fat cells, and hair follicles, and they don't suffer irreversible damage. So if we want to compare the more traditional radiofrequency versus cryoablation or PRF, like what can we say? When it comes to, we're talking about myelinated nerves to start out with. RFA will be an irreversible lesion because it completely coagulates the nerve, whereas cryo is reversible. And PRF is, of course, reversible. This has some positive and some negative effects, right? If you get it right and the patient has really good relief, then it's a bummer that they have to come back after some time. But on the other hand, if it doesn't work so well, it's still only 6 months. Now, cryo and RFA are similar in that they both will cause a sensory and motor loss. If you get the nerve again properly, it will lead to a functional loss, just like lidocaine. Is there a neuroma formation? Radiofrequency? Yes, probably yes, because you destroy the whole nerve and the nerve grows up, and that's when it starts firing, and the patient will report pain at about 6 months after the procedure. And then you need to go more proximal, because once you have a neuroma, you cannot lesion the nerve at the same location. With the cryo, there is no neuroma formation. Placement is harder with cryoablation because the probe is much bigger, as you could see. So it's a bit of a learning to get it right with cryoablation, because it really covers the whole area. If you have a good view with ultrasound, then you barely see the tissues. Similarly, if you do fluoroscopy guided, then the size of the cryo probe is so big that you can't really do coaxial view. You need to do a bit of off coaxial to see your probe tip. Now, when it comes to the innervation certainty, cryo makes the biggest lesion. That's the biggest certainty of success. Pain relief is pretty much instantaneous with cryo, and that's another beautiful thing about it, that the patient comes in with knee away and cannot step up on the stairs, and then as he gets off the table, they can actually move their knees much better. Cryo lasts 6 months. Radiofrequency lasts, let's say, 6 to 12. The PRF, I would say 3 to 6 weeks is what I experienced, and most of the literature also talks about 3 to 6 weeks relief, although some goes longer. So to imagine, how do we think of cryo? Here is a case. What do we do? There is an osteosarcoma at the femur. It encroaches on the sciatic nerve. Surgery happens, and there is sciatic pain post-surgery. What do we do? Do we do cryo, pulse radiofrequency? How do I pick the best answer for the patient if I have all the tools, right? So very important to consider the clinical scenario, because each scenario is very different. If you think of this elderly lady with end-stage cancer as a patient, it will give you a different approach, right? You can think of pulse radiofrequency, and you will say, no, because the likelihood of success is very little, and you want immediate, strong success for the remaining of her life. Then you could do cryo, likely good success, and you can cover even bigger nerves. Or you can do radiofrequency. And here, loss of function is not necessarily a problem, because she's bedridden anyway. So giving her pain relief, maybe decreasing the opioid consumption, may even prolong life. It's a very different scenario if we are thinking of a young woman. Their sciatic functional loss is not an option, right? So you can try pulse radiofrequency and see where you get. You don't want to cryo because you don't want to decrease sciatic function, and it's the same with the radiofrequency. Now, what are the clinical applications for cryo then? First and most important, this is the general approach. You want to have a successful diagnostic block, and then you can cryoablate. Which nerves can you target? Essentially, all of them. What's important, that you need to confirm that the nerve is the actual source of the pain, which again goes back to history, physical exam, and diagnostic injection. You need to understand the function of the nerve, so we can consider, if we take away sensory or motor, is that a problem or is that a joy? And of course, you need to be able to identify the nerve for procedural purposes, let it be ultrasound or fluoroscopy, or landmark guided. Supraorbital, I would say, is a beautiful and easy target for cryoablation. The supraorbital neuralgia will give you this very typical pattern of supraorbital nerve pain, but sometimes it can be mistaken by migraine or cluster headache or even frontal sinusitis. The history often would contain car accident when the patient would hit the head against the steering wheel or the windshield. Or I had a patient who had a tire exploding as he was fixing it, and some piece hit the supraorbital nerve. So once the history is clear, then you do the physical exam, and palpation over the supraorbital nerve will reproduce the pain. Then you do a diagnostic injection. Again, here not even a cc, just a quarter or a half a cc at most. And then if it's good pain relief, again I suggest more the 80% than the 50%. Now here there are a couple of things that you want to be aware of. The nerve is so superficial, so you could easily freeze the skin. And there are a couple of tricks to avoid that. You could place a warm finger over the skin, or you can start dripping saline, and that prevents the skin surface from getting freeze bite. Also, you want to pull the eyebrow away just to make sure that you don't damage the eyebrow. You can cryo the infraorbital nerve. This is again something that gives facial pain. It can be confused with maxillary sinusitis. It's due to facial trauma. The Lefort fractures can cause it. And pain will be worse with smiling and laughter. You could inject like this on the picture extraorally, but you can also have an intraoral approach. So this is the palpation, and physical exam will reproduce the pain. And then you do the diagnostic injection, again with 1 cc of local anesthetic, or you could do the intraoral approach. And the risk of infection is higher with the intraoral approach, particularly because it's a much larger cryo probe, so I would always give pre-procedure antibiotics with these. Especially that I did have a complication with inferior alveolar nerve abscess with an intraoral approach. Now, occipital nerves can cause headache. The greater, the lesser, and the third as well. The patient will complain about a headache that starts at the back of the head or neck and wraps up to the back of the head, refers to the frontal area. They would often say they have pain behind the eye. And the entrapment is very often not up at the occiput so much, but more proximally the inferior oblique capitis muscle. Therefore, the lesion we will do more proximally at the inferior oblique capitis muscle level. Now to get oriented, this is C2 spinous process. Again on the model, C2 spinous process. The ultrasound probe is oriented towards the C1 transverse process, Now the inferior oblique capitis muscle runs exactly between these two structures. The occipital nerve comes out from underneath from C2, transmedially, and then back up to the occiput. Of note, at this level, the occipital artery does not run together with the inferior oblique, with the greater occipital nerve, and that is because the artery is the branch of the external carotid, and this is coming from C2 exiting nerve root. Now here is the ultrasound image, so the ultrasound probe is unchanged. You can see this is C2 lamina, right? This is this part, C2 lamina. This is the junction of the C1 and C2 vertebral body, so roughly here. And here is the inferior oblique capitis muscle, the semispinalis, and the occipital nerve. If you do a diagnostic block, this is what I find easiest. and fastest and nicest for the patient out-of-plane approach. However, one needs to remember that the needle is pointing exactly towards the spinal cord, so there is trouble unless we have a clear understanding of what we're doing. Here you can see the cryoablation. The needle is entering the skin or the probe at the midline, so this is the head of the patient, that's towards the feet. And from midline you can reach both the left and right occipital nerves. And again, we need to remember the occipital, the vertebral artery is in the trajectory. It's more challenging than to do a regular occipital nerve block, and the reason is that there's only a very little window where you can beautifully visualize the occipital nerve, and you need to place your cryoprobe in that very plane to be able to see everything at the same time: the nerve, the cryoprobe. If you have separate planes for the nerve and the cryoprobe, it's just not a good procedure. So here it is, the midline, the spinous process, the inferior oblique capitis muscle, and this is the actual ice ball shaped at the location of the nerve. Now what you need to be aware of with this approach, again here's the probe, the ice ball, that your cryoprobe is actually pointing towards the vertebral artery. It's not very close, but potentially you can push the probe further in and then there is trouble. Today we are going to perform a right greater occipital nerve cryoablation. The patient is a lovely 80-year-old lady who has post-herpetic neuralgia. Her zoster came in 2018, and ever since she has pain at the right side of the occiput. She cannot lay down and she has special pillows to facilitate sleeping, but it's still a problem. Previous diagnostic blocks, actually many of them, gave her good but short-standing relief. Nevertheless, as the patient came to us, today we repeated it with 2 milliliters of lidocaine 1%, and it did indeed decrease the pain. Now you see that her anatomy is a difficult one. So before we get to it, I'll show you a good anatomy so you know what to relate to. So when you're looking for the occipital nerve, there are 3 steps, as with everything. Step 1, you palpate the C2 spinous process, and you place your probe over it. Then you see a bifid spinous process, and then just flipping it, and then you slide towards the C1 transverse process. So you can see the angle of the probe. This is C2 spinous process, and the other side is angled towards C1 transverse. And what you see here is a nice fibers of the inferior oblique capitis muscle. And always between the spinous process of C2 and the transverse of C1, if you split the distance to 1/3, 2/3, the nerve is always sitting at the 1/3 closer to the C2 spinous process. And here you can see the occipital nerve. If I scan cephalad, you will see the nerve is moving medially. If I scan caudad, you can see the nerve is going laterally, and then it dips under the inferior oblique capitis muscle in order to join the C2 nerve root. So again, cephalad scan, caudad scan. Now with this patient, you really cannot see the nerve this beautifully, so I will have to rely on the distance, the 1/3, 2/3 rule between C2 spinous and C1 transverse. So the equipment for this procedure is fairly simple. I have lidocaine 1% with a 25 gauge local needle to obtain local anesthesia. I have a 14 gauge IV cannula that serves as an introducer, and I have a cryoprobe 1.3 millimeter wide.
before we get to the procedure, of course, we're going to test the cryoprobe to make sure it functions properly. So we're testing if it actually freezes, which this one always does, but I'm owned by old habits, so let's freeze. Again, I can already see it's working, but I'm freezing a bit of Lido. So this is functional. So here we have the patient in a prone position. Neck is flexed. You can see the hairline, and here are the shoulders. First step, I'm palpating the C2 spinous process, and I'm placing my probe over. Oh, she doesn't like it already. I'm sorry. And then I'm sliding towards the affected side, towards the C1 transverse process. Now what you can see here, I already checked. You can see that you cannot see. It's not looking as nice as the previous demonstration, but we can still try to find it. And again, we are looking at hypoechoic structure that dives under the inferior oblique capitis muscle as you go distal, and if you go cephalad, that should be moving medially. I think I can see it, and I will put an arrow when we get to movie editing. I'm looking always here, 1/3 distance from the C2 spinous process. And possibly I will do multiple lesions to make sure that I get it right. But I think I can visualize it right now. My entry point is at the center of the screen, center of the midline, sorry. Pity, ein bisschen ein Nadel. Das ist Lidocaine. And you can again see the trajectory. It's key to understand that. Sorry, it's the worst. Danke. It's key to understand that there is spinal cord in the vicinity. And also that in the trajectory of this needle, there is vertebral artery. So we need to be extra cautious. Ist das scharf? Ja oder nein?
Nein.
Super. So this is the introducer. Straight through the skin. And then aiming towards my target. With this procedure, as with many others, as your window of seeing the target is so little, it's crucial that you actually put your needles in that exact plane, so there has to be not much looking for your needle. So you can see that my cryo probe is on top of the inferior occipital nerve, and I'm planning to do multiple lesions really for the success today, because I can't visualize the nerve as nice as I would like to demonstrate for you. I've pulled back the introducer, and we're ready for the first freeze. Es geht?
Ja.
Danke. So here you can actually visualize the ice ball shaped on the top of the inferior oblique capitis muscle. If in an ideal demonstration, what I would do, I would identify the nerve as it runs into the ice ball, and then it leaves the ice ball. Now that I cannot demonstrate today. But you can see the series of lesions that I will make on the top of the inferior oblique capitis muscle.
Now let's get to intercostal neuralgia. This is the area that has possibly the most available literature. It's been studied for thoracotomies, in children in pectus excavatum surgeries, and also for rib pain. We know about intercostal nerve blocks, so of course it's T1 to T11. It's at the caudate part of the rib, and it provides sensory innervation to the chest wall and the abdominal wall. And of course, it motor innervates the intercostal muscle and the abdominal wall as well. Intercostal neuralgia can be a result of herpes zoster, rib fractures, and thoracotomy pain. Here you can see the procedure. You can see the patient is breathing nicely. There's the pleura. And this is local anesthetic I'm injecting just for orientation. This is towards the head, and that's towards the foot. And here is the introducer. The entry point is over the lower rib, but I'm targeting the T10 rib. Again, you need to be really aware of the pleura, and the introducer is targeting the caudate portion of the rib, nicely visualized. The skin entry is about 5-6 centimeters off midline, and certainly medial or proximal from the actual nerve injury. Now here you can see that my introducer tip is almost at the pleura. That's the time to change to the cryo probe. And once you enter with the cryo probe, again you're extra cautious to visualize both the probe and the target, because you certainly don't want to pierce through the pleura with a needle or a probe that's 1.3 millimeter wide. Once you arrive at the caudate part, just beneath the rib, then you can freeze. Now this is a systematic review and meta-analysis of 196 patients who underwent pectus excavatum repair, and the finding is that it certainly shortened hospitalization, and in many of the studies it actually led to much decreased opioid use. Now another very common problem is iliohypogastric and ilioinguinal neuralgia. And the patient will typically come after either a C-section or laparoscopic or open hernia repair. Usually by the time they come to you, they are through everything. They had endometriosis as a diagnosis and then excluded. They had all the GI endoscopies, so they're pretty well investigated by the time they come to you, and then you palpate just medial to the ASIS, 2 centimeter medial and 2 centimeter caudate, extremely pressure sensitive, or the scar tissue is pressure sensitive. You place your ultrasound probe and identify the muscle layers. This is lateral with the iliopsoas and the ASIS, transverse abdominis, internal oblique. We all know this anatomy, and in between them there is ilioinguinal and iliohypogastric nerve. Once you did your diagnostic block, then you're ready to freeze. Here you can see the ilioinguinal, again lateral ASIS, iliacus muscle, and the abdominal muscles, and then I placed an ice ball onto the ilioinguinal. Here is the cryo probe, and it's with ultrasound guidance. It seems easy, but we need to be aware that there is a lot of anatomic variabilities. This is a dissection of 100 cadavers, and what they found is that the emergence of the ilioinguinal nerve is really at quite a big area. And of course, Lee Dallon and his publications give a lot of information on the variations between ilioinguinal, genitofemoral, and iliohypogastric as well. The next will be the Agnes syndrome, very often overlooked. This is also one where the women got the diagnosis of endometriosis, got the surgery, nothing happened, the pain is unchanged. They come to you, you palpate at the lateral part of the rectus, at the rectus sheath where essentially the intercostals perforate and come superficial. This is where they are. So just to get oriented, there's the head and the feet towards this way. This is midline, and here is the rectus muscle, and these tiny nerves pierce through at the lateral edge of the rectus. You palpate, then you do a diagnostic injection, and if it is positive, then you're ready for cryoablation. You could do ultrasound guided. This image is from Dr. Trescott. I find it tricky to really visualize these cutaneous nerves myself, but palpation and stimulation comes really handy. You can cryo pudendal nerve. Patients will report with perineal pain, anal pain, vaginal pain, clitoral pain, or scrotal pain. And you can target the pudendal nerve here where the image shows fairly distally. This is ideal because you can get the selective branches, and then of course you only want to take away function of a nerve as much as it's necessary. If you do the cryoablation more proximally, just medial and posterior to the ischial spine, then you get the larger, the whole pudendal nerve before it branched apart. So then it will compromise function of all the branches. When you do this, it's done based on stimulation. You want to make sure the patient has good stimulation in the actual area of pain. You can perform cryoablation to denervate the facet, so denervate the medial branches. It's usually done by radiofrequency, much more common, much more studies available. However, cryo creates a much larger lesion, easy placement compared to the SIS technique where you have to come from posterior and lay the probe parallel to the nerve. All those troubles can be avoided with a gigantic ice ball. Also, because the cryo allows the nerves to regrow and the multifidus function will return, and the motor function returns much faster than the sensory function. So this is how it looks, relatively large cryo probe, and it's placed to the L5 dorsal ramus. There's not much evidence available, but this is from a 2018 publication. There are essentially 3 studies identified, 50, 76, and 46 patients who underwent lumbar facet cryoablation, and they're all successful. Now we can cryoablate the hip joint. And we understand now, since these beautiful publications by Gardner and Philip Peng and Ann Agur and John Tran and the group, where exactly these nerves lay. So we can cryo the hip as well, ultrasound guided and fluoroscopy guided too. I'm going to show you a part of an ultrasound guided just for change, because it's very long to listen for a whole hour. So here is a procedure video for change again. To get oriented, let me start this for a second and then I'll show you the anatomy. So here you can see the AIIS, anterior inferior iliac spine, the acetabulum, the iliopectineal eminence, and here there would be the anterior superior iliac spine. And my probe is coming from lateral to medial in plane. So lateral to medial, and you keep your eyes here because that's where the ice ball is going to be. We start it again. So you can see the ice ball, the probe, and as I scan, you can here and there identify the anatomy properly. Again, it's lots of extra calcification that are causing the pain partly, or signs of the pain, and this is AIIS. And this is how it looks fluoroscopy guided. At the teardrop is where the cryo probe tip is located. And these images, I think, is awesome because the patient has a hip replacement, which should have solved all her problems. But clearly, the pain is still around. And then again, cryo comes handy. These are studies that demonstrated the benefits of radiofrequency of hip, radiofrequency denervation of the hip. All of them are a low number of cases, but positive. Now, this is radiofrequency, and we don't have anything, according to my knowledge, on cryoablation for hip denervation. With that, though, I can add my personal experience. Cryo is by far my favorite over radiofrequency when it comes to joint denervation. You can cryo infrapatellar saphenous. You can damage that the blunt injury to the tibial plateau or total knee replacement. Often with knee endoscopies, they would injure the infrapatellar saphenous nerve, and patient could develop CRPS. Now you can identify it with ultrasound. You can see this is the tibia, and there's the nerve. You can place your probe. This is landmark guided, but you can place it ultrasound guided as well. Again, here is the nerve, tibia, medial meniscus, and femur. What I observed is that the nerves that are a problem are really always visible. They are just swollen. Happy nerves don't get so swollen. And here you can see the cryo probe placed over the nerve for cryoablation. With this particular case and situation, I say it's very nice to have feedback from the patient. You place your probe, you stimulate. Is this where the pain is? And if the patient confirms, yes, this is exactly my pain, then you can freeze it and expect good success. Again, cryo probe and the nerve. Now, knee osteoarthritis can respond really nicely to cryoablation of the superomedial, inferomedial, and supralateral genicular nerves. Now, again, we have extensive studies on the anatomy. We can place radiofrequency or cryo probes X-ray guided. I prefer ultrasound guided because it allows identifying the soft tissue and the target properly. This is a randomized double-blind sham-controlled multicentral trial with 121 active treatment where they cryoablated the infrapatellar saphenous nerve, and they studied the WOMAC scores. And what they found, there is significantly decreased knee pain compared to sham. And this is another one, again, a cryoablation of the infrapatellar saphenous and the anterior femoral cutaneous nerve on 100 patients, significantly better pain and less opioid use after total knee arthroplasty. Here you can see the procedure. This is local anesthetic that is just being placed. You can see the needle exactly at the tibia shaft and condyle. And here is the MCL, which serves as a landmark You want to get just anterior to that. This is the introducer. You almost always need an introducer, because the cryo probe is, even though you call it sharp, it's still such a big trocar tip. It's hard to guide. Here you can see the cryo probe. I pull back the sheath just so it doesn't isolate the tip of the cryo probe. And then it's ready to freeze. And because this is such a superficial area, it's very easy to visualize the ice ball immediately. And you can see the size of the ice ball, and it's still growing. I don't know if I have the movie of it, but it's big. So that again compensates for challenging anatomy or any difficulty with the placement. Neuralgia paresthetica, another good one to do cryoablation. The patient will complain of pain at the lateral thigh, burning, numbness. It can be entrapped at the ilioinguinal ligament. Of course, it's more common in obese patients, in pregnancy. It happens after a tummy tuck surgery because they damage it, and people who carry a holster belt or seat belt can damage the lateral femoral cutaneous nerve. This is the anatomy review quickly, as it runs under the inguinal ligament, over the sartorius, and just lateral to the sartorius, medial to the tensor fascia lata. That's a good point to identify it, and then you can track it backwards. So when you do the ultrasound scan of the lateral femoral cutaneous nerve, again, what we'll see is that the damaged nerve is always bigger than the normal side. You can tell it by the surface area as well. Now here, this was a patient who actually had the tummy tuck surgery, and therefore I wanted to go as proximal as I could to get to the area proximal to the injury of the nerve. So here, this is the sartorius, this is the sartorius tendon, this is the tensor fascia lata, this is lateral, and in between there is the lateral femoral cutaneous nerve. So I placed my cryo probe from lateral to medial and performed my first freeze. This is the actual ice ball, and this is as the ice ball grows. And of course, then I repositioned and stimulated to make sure that I get it all. And digital nerves are very good targets for cryoablation. Patient would have a Morton's neuroma, which is a dull or burning pain to the toes or ball of the foot. It increases with standing. Very common in diabetics and also with patients who wear poor-fitting shoes. This is how the freezing looks under X-ray. You can identify the neuroma under ultrasound. It's very nice to match it against the MRI until one finds it. And this is where the ice ball is located. So these are the metatarsal shafts or heads, and in between there is an ice ball. So in summary, when the nerve regrows, function returns to normal after cryoablation. Therefore, the procedure can be repeated if needed. It provides a window of opportunity for painless rehabilitation, which is very important. Get your patients back to physical activity. And it's a minimally invasive office procedure. Now, cryo is coming up and gaining popularity, partly because we are coming to recognize again the peripheral nerve pathology. It's so important. We have new imaging techniques where that means that the nerves become alive. We can see them. It makes it true pressure. We have the new equipment. More and more people have access to cryoablation or device. And it is the treatment of choice for treatment of entrapment of large myelinated nerves, which do not have many other options. Thank you very much for your attention, and I'm ready for questions. And this is my family, my son and my husband on a lovely winter hike this year. Thank you.